I think the edition before, kind of the same thing, right? Before this edition, there was a lot of changing around of the chapters and renaming of the chapters. It would seem like, since we're going to be talking about technique in this, for this next test, that it would be under chapter 14, digital radiographic technique, but technique is really in chapter 15, which is image acquisition, which I can kind of understand in the quantity and quality of x-rays that we make affect that image acquisition, but still it just doesn't seem quite like the proper description of the chapter. So what we're going to talk about in this chapter is a number of things, and we may go a little bit deeper than what is just in the chapter itself. There's going to be some math in this, okay? But I want to put your mind at ease right now. For this semester, what I primarily want you to grasp is the concepts, okay? So I'll show you how the formulas work for what we're going to talk about in this semester. I'll show you how they work. I'm working for you. But I'm also going to show you the shortcuts, which I really kind of already have. But we're going to refresh those, tell you the things to watch out for on the tests, especially I don't know that we'll get to it today, but maybe next Friday, the inverse and direct square laws, and because you mix those up a lot because they're so similar. So the math, for the most part, if you know how the formulas work, you should be able to work them out in your head. And the dirty secret is that applies all the way through the registry. Really, if you know how the different formulas work, you should be able to pick up the right answer on the test. Now, it's not going to be this way throughout the curriculum. When we go back through imaging in sophomore year, you're actually going to have to work the questions. You're actually going to have to work formulas. So what I mean by that is right now, and we've touched on this, inverse square law tells us radiation exposure changes with changes in distance. So if you increase your distance, your radiation exposure goes down. We've used the example of being in a fluoro room and stepping away from the table and all that, just to lower your radiation dose, right? So if you double your distance, how much does your dose decrease by?
Factor of 4.
What's that?
Factor of 4.
A factor of 4, exactly. It decreases by a factor of 4. So you know that that's always going to happen. So if your dose is 2 at, I don't know, 1 meter, then well, let's make it easy. If it's 4 at 1 meter, you increase your distance to 2 meters. What's your dose? It's a factor of 4. It's down by 1, or down to 1, correct? So those are the kind of questions that I'm going to ask you for this particular test. But when we get into sophomore year, you're going to have to go from like, I don't know, 1 meter to 1.5 meters. Okay, so you're going to have to know how to work them. You're going to have to actually work them in your sophomore year. But for this semester, I just want you to grasp the concepts. So the math isn't hard, providing you know the shortcuts. Okay. So in this chapter, then, what we're going to cover are our exposure factors. We're going to talk about imaging system characteristics, which we've done some. We're going to talk about patient factors, again, which we've done some. We're going to talk about image quality factors, technique charts, which you're probably not real familiar with, except for, you push the button and it gives you kind of a set of parameters for your photo timing, or even an MA in a time setting if you're not, right? So that technically is a type of technique chart. We're going to talk about how AECs work. Whenever we adjust different things, like if we increase or decrease kVp, what's happening with AECs and how they, the exposure is adjusted using the AECs. Probably not going to talk about TOMO because it's not on, it's come off of the registry. I might touch on it and kind of explain how it is that TOMO is kind of like very first generation CT. The T in CT means tomography, and tomography is just using motion to try to get rid of some sort of artifact. And we're going to talk a little bit about macro radiography as well. And what macro radiography is intentional magnification radiography. So there are 4 primary exposure factors. There's kVp, MA, exposure time, and distance. And in this context, what we're talking about in distance is SID. Okay, so we're going to get into OID later on. OID can also affect image receptor exposure. It can also affect patient exposure as well. But in this context, with the 4 exposure factors, that's SID. So it's source to image receptor distance. So on all of your exams, those are the 4 things that you manipulate. Generally, you shoot at 40 or 72 inches. You have relatively set kVp levels for different anatomy types. So chest x-ray is probably going to be high kVp, abdomen's going to be lower, we'll talk about why, and then extremity work's going to be lower than that. So those are all things that you have to manipulate. They're all under your control, and everything else is a secondary factor. So busy slide, a lot of stuff, no notes. So they're all here. All right, so with kVp controls your beam more than any other factor. All right, and you may have a tendency to think, okay, well, distance, SID is pretty big, right? I mean, you double your distance and you're either going to have 1/4 of the exposure, or you're going to have to quadruple your mass in order to, get the right exposure. Yeah, but with kVp, the kVp of 15% increase does what at the image receptor? We've kind of touched on this. We hadn't beat it into the dirt yet. We will. But what happens at the image receptor if you increase your kVp by 15% and that's the only thing you do? It doubles the exposure, exactly. So 2 doubles, if you increase by 30%, it would pretty much do the same thing as the inverse square law, right? Or the direct square law, if you're applying mass. We'll get there probably next week. So if you double your kVp, can you imagine how much more output you would have? It'd be pretty significant. So more than any single other factor, your kVp is going to affect your exposure at the image receptor. And that's mainly where we're going to be in this chapter, technique to affect the change at the image receptor. Those do come with, the understanding that that's also going to affect patient dose as well. Okay, so it controls the energy level of the X-ray beam. And it has a anti-shake thing, so we'll see how that turns out.
It's just testing for you.
Yeah, it's just testing it out. When I had to put it back to factory reset settings, I don't know that I've, enabled the shock or whatever keeps it from jiggling around. So we'll see how that turns out. It'll be fun. Yeah. Right. So it controls quality of the X-ray beam, and the reason we say it controls the quality is because penetration is quality. If the X-ray beam doesn't penetrate anything, then it's of no use to us. It's poor quality. We can't make an X-ray. Right? So we have to have some sort of penetration. So kVp controls the penetration. It controls the average energy of the beam. So not only does it control the peak energy, but it controls the average energy, pushes it towards the high energy side, but it also gives us significantly more under the brim spectrum. So we drew that out last week. The brim spectrum goes up, it goes towards the high energy side, and a peak increases, and it determines whether or not we get a characteristic spectrum. So all of that stuff is controlled by kVp. So with the increase in kVp, what we get is we lose interactions, and all types of interactions. Kind of drew that out on Wednesday. But significantly, we decrease photoelectrics, right? So we get more penetration, more penetrated scatter. So we get more exposure. Secondarily, it controls quantity, and we say secondarily, it would seem like it would be primarily controls the quantity because it's so significant. You increase by 15% and the quantity goes up by 100%, right? At least at the image receptor. But because of all this other stuff, we don't want to primarily use it for this moment in time anyway. We don't want to primarily use it for the control of quantity. We want to use mass because there's a direct relationship between mass and quantity. We increase mass by 15%, then the quantity goes up by 15%. We double the mass and the quantity doubles. So I do believe, again, that sooner or later we're going to use kVp more to control the quantity, but just not yet. So in our kVp questions, we have to consider a number of different things. What's happening inside the tube, what's happening coming out of the tube, what's happening in what we refer to as the useful beam, what's happening inside of the patient, and what the result is on the image receptor. So in the tube, what we've got is a change of potential energy. So when I'm talking about potential energy, I'm talking about the difference between the positive and negative charges on the anode, between cathode and anode. So when we apply the kVp, the cathode becomes much more negative to push those electrons across. The anode becomes much more positive to pull those electrons across. So the resulting, or what that results in, is an acceleration of the electrons across the tube. The higher the kVp, the faster the electrons go. And they travel very, very fast. There's a couple of videos, I think I've spliced them together on the YouTube page that shows exposure without the collimator housing on. I don't know if anybody's seen that. I'll try to find it and put it in Canvas. But it's just a spark. It's they go across the tube in twinkling of an eye. It's not even blink of an eye. They travel across the tube. Some websites will say approaching maybe a third to a half of the speed of light. So what controls that speed? Well, it's kVp. As kVp goes up, the negative becomes more negative, positive becomes more positive, opposites attract, and they travel faster. So as kVp goes up, we get more kinetic energy in those electrons. Since they're all electrons, the only thing that we can do to control the kinetic energy is increase the speed. They're electrons, so you're not going to increase the mass, you're just going to increase the speed. So you increase the potential energy by changing those positive and negative charges. That affects the kinetic energy. Once you make your exposure, they jump across the X-ray tube, and then the speed of the electrons increase with increased kVp, and what that gives us is a higher average BREM spectrum. So we're going to get, and if we don't do anything else except for increased kVp, we're going to get two things. One is we're going to get all the stuff in the BREM, all the stuff in the BREM spectrum. So not just two things, but we're going to get a higher average, we're going to get a higher number, we're going to get a higher peak, we're going to determine whether or not we have a characteristic spectrum. And then we're going to get more penetration through the patient. So we get all that stuff with the BREM spectrum, and we're going to get more penetration with the patient. So with the increase in kVp at 15%, it's important that you understand that the doubling occurs at the image receptor post-patient. It doesn't double the patient dose, okay? But because we get more penetration through the patient, we get more exposure to image receptor, and the image receptor exposure doubles. Patient dose does not quite double, okay? It still goes up pretty drastically, but it doesn't quite double. We get more penetration to the patient. We'll talk more about that here in a bit. So changes in kVp. On the target, we get higher peak energy X-ray photons, higher average energy photons, more X-ray photons when nothing else has changed. So if you don't change your mass, you don't change your distance, then you're going to have an increase in exposure. And it's a direct and exponential relationship. Right? That meaning a 15% change doubles the image receptor exposure. You double your kVp, and your image receptor exposure is going to go up by a lot, exponential, right? So in the useful beam, kind of the same thing I was just talking about. We get more penetrating beam, and the potential for a lower dose. We have the potential for a lower dose when we adjust our mass. That's your 15% rule. So we're going to talk about that also this semester. 15% rule is where we manipulate kVp in mass to affect the change in patient dose while maintaining image receptor exposure. Generally speaking, what that's going to result in now is that as you increase your kVp, you're going to reduce your mass to decrease patient exposure. Back when kVp was our main control of contrast, then we could go either way with it, right? But our main control of contrast now is not kVp, but it's rather the computer algorithm. So it doesn't really matter as much what kVp we use. Maybe a tiny bit it might change, or it might affect it, but primarily what's going to control the contrast being the difference between tissue types, bone and soft tissue, for example, is going to be controlled by the computer algorithm. So since kVp doesn't control that, there's really not a whole lot of reason to decrease kVp and increase mass, right? Because if you decrease kVp and you increase mass, what are you going to have? What's going to happen with the patient?
They're going to absorb more.
They're going to absorb more. Their dose is going to go up, right? So where we used to have to do that to maybe ferret out some contrast in the patient to try to be able to visualize, some structures better than others, that's all taken care of with the computer algorithm now. So there's really not a whole lot of reason to decrease kVp and increase mass anymore. So most of your questions are going to come at you. In one of two ways for the 15% rule. You want to reduce patient dose while maintaining image receptor exposure. How are you going to accomplish that? Increase kVp, decrease mass. So you might have a question that says you want to increase differential absorption. So word to file away, or words, differential absorption. That is absorption in different types of tissues. As kVp goes up, you penetrate all tissue types more evenly. Okay, so if you shoot an abdomen at 50 kVp, you're going to penetrate the patient?
A little bit, maybe.
You will. You'll penetrate them. In that case, it might be an ugly x-ray. You can penetrate a lot of stuff, more than what you think you can at 50 kVp. You really can. Play around with it in clinicals. Just pick some stuff to shoot. But what you're going to have is a lot of photoelectrics, right? So if you shot that KUB on a patient at 50 kVp, the patient dose is going to be through the roof, right? Because they're going to absorb, even the scatter that they create, they're going to absorb a lot of it, right? So if you increase your kVp to 100 kVp, though, what you're going to get is less differential absorption, more penetration, less differential absorption. So sometimes you may have a question on manipulation of kVp and mass that says you want to increase differential absorption, which means that you want to take advantage of lower kVp to absorb differently in different tissue types. So you want to increase differential absorption. That should be your signal to decrease kVp. In clinical practice, you're just not going to do this, but you would decrease kVp and increase mass. So decrease by kVp by 15%, increase your mass by a factor of 2. Okay? So the problems with high kVp, there's a couple of them, really. And that is, one, we talked about it on Wednesday, is more scatter radiation is going, you're not really going to create more scatter radiation in the patient, but more of that scatter radiation is going to penetrate through the patient and make it to the image receptor. That, again, used to be a big problem whenever kVp was the thing that was most responsible for our contrast, because any scatter that makes it to a film screen radiography image receptor is going to decrease contrast. Okay, but what's the main control of your contrast now? Not mass.
No kVp?
Not kVp.
Oh.
None of this we're talking about today.
The computer?
The computer. The computer is the main thing that controls your contrast now. So I won't say that scatter is not an issue anymore, because it is. And we're going to talk about the different ways that we can kind of not really eliminate, but mitigate some of the problems with scatter radiation. Grids, virtual grids, collimation, compression, things like that. We can do all those things to minimize scatter radiation, but with increased kVp, we're going to have more scatter radiation to the patient. The second thing is that we're going to have a higher potential for creating quantum model. And I think I talked about that on Wednesday too. Quantum model, we've been not able in our sophomore experiments in the last 2 years, we haven't been able to demonstrate quantum model at all. So is it even a thing anymore? I don't know. Our image receptors are sensitive enough that that really any exposure we haven't been able to demonstrate quantum model. Still testable, so you got to lock that in. So what is quantum model? It's where you don't, it's a noisy signal is what it is. Okay, so we have two different types of noise. One is fog and the other is quantum model. And where quantum model comes in, it's kind of like static on the radio, static on your television. It's kind of the same thing. You don't have a strong enough signal to get a good, your radio sounds fuzzy, your TV looks fuzzy, right? Because it's static. Same thing here. You don't have enough signal being mass, incident on the image receptor, and so you get a noisy image. It's just kind of speckly looking. Quantum, not enough. Model, kind of a speckly looking appearance. Quantum model, you don't have enough mass to get a good signal. If you don't have enough mass to get a good signal, you may get that grainy appearance, okay? So why does kVp affect that? Well, going back to here, 15% rule, if we use too high kVp, we make one exposure and it's a good exposure, and then you come back and you use 15% more kVp, what are you going to have to do with your mass to make the same exposure?
Lower it.
You're going to have to lower it by a factor of 2. So too high kVp can cause your mass to be so low that you potentially, theoretically anyway, could introduce quantum model. Okay? So that's problems with kVp. So behavior of photons, what really changes whenever we increase or decrease kVp as far as the individual photons go? And we already talked about the energy level changes, right? The speed of the photon remains the same even though the speed of the electron changes. But what really changes? What determines the difference in electromagnetic radiation, the energy level of electromagnetic radiation? Two things.
Amplitude? Or frequency?
Close. Huh?
Frequency?
Frequency and
Wavelength?
wavelength. Frequency and wavelength, right. So really, any level of electromagnetic radiation, those are the main two things that will change, is frequency and wavelength. So between red light, blue light, yellow light, that's just frequency and wavelength. Ultraviolet, frequency and wavelength. And in X-rays and gamma rays, we used to not be able to create X-rays in the same energy level as gamma rays, but we can now, right? So from an energy level, frequency and wavelength level, there's no real difference. The difference, though, is where they're created. With X-rays, we create X-rays in two different ways. We get the brims as the electron goes around the nucleus, slows down, kicks off an X-ray photon, and then we get characteristic whenever we get two electrons knocking into each other. And if you have two electrons knocking into each other, one knocks an electron out of its shell. As it knocks it out of its shell, it replaces with another one. So anyway, all this goes to say, where are X-rays created? Are they created in the nucleus or not in the nucleus? Not in the nucleus. So where gamma rays come from? The nucleus. Right, so their origin is really the only difference between the two at this point. So MA, we got to talk about MA in time
separately because they're two components to make the, overall mass. So intensity just refers to the quantity. The quantity refers to the number of electrons that we send across the tube. The more electrons we send across the tube, the more X-rays we create, and that is our intensity. All right, so what controls that is filament current. Up to the point of exposure, really we don't have tube current, so we don't have mass. We're just talking about MA at this point, but we don't have mass until we hit the kVp, right? So at this point, the only thing that we have is filament current. So the MA circuit directly controls how hot you make the filament. Heating of the filament, we get thermonic emissions, formation of a space charge. The higher the MA, the hotter it gets, right? So two things control the heating of that filament, really. One is the MA that you select, and two is how long you stay on the rotor button. So we've talked about that before. This is where really our tube heat comes from, is our MA overall mass and our prep time. So it controls filament current. An amp is just a whole lot of electrons, right? So we talked last semester about how inefficient X-ray creation is. And what we said was that only about 1% of the X-rays that we create, and it really kind of depends on the kVp level we use, but anywhere from 1 to 10% of our X-ray, the electrons we send across the tube, become X-rays. At very high kVp, maybe 10%. At lower kVp, 1% or less, right? So it's very, very inefficient, but it's a numbers game too. So 1 amp equals that many electrons, or actually it's 10 to the 18th power. We don't generally use a 1000 MA station. A lot of your machines only go up to 800. I've worked with some that went all the way up to 1200, but those were, kind of specialty units that were designed for short exposure. So 800 MA, even if we were only shooting on 100 MA station, that's still a lot of electrons, right? So if we made a 1 mass exposure, we're sending a lot of electrons across the tube, and if only 1% of those become X-rays, we've still got a lot of X-rays, right? So it's just numbers game. Even if with all those that we send across the tube, if only 1% of those reach the image receptor, that's still a lot. Right? So just walking through it, we have a 1 mass exposure, we've got that many electrons. If 1% of those become X-rays, that's still 6.3 times 10 to the 15th power. If only 1% of those make it to the patient, that's 13th power. If only 1% of those make it through the patient, that's still 11th power. That's a lot of zeros, right? So it's a numbers game. We throw a lot of electrons at the target and just get a few of those being X-rays, and only a few of those are decent X-rays, and only a few of those are gonna make it through the patient. But the few is very big, right? So again, moral of the story here is higher MA, more electrons. We get a lot of electrons. So we talked about this on Wednesday with Brim spectrum. Whenever we change our MA, it has no effect on the potential energy and kinetic energy. That's all kVp. We increase kVp and we get those two things. Doesn't have any effect on the beam energy, no effect on penetration, except for you're going to get whatever change you make. If you increase your mass by 100%, so you had 2 mass, you now got 4 mass, then you're going to have exactly twice as many penetrate the patient. So what this is talking about, as far as penetration goes, is the percentage of penetration versus photoelectric, right? There's no effect on that, no effect on wavelength or frequency, so the only thing that you change whenever you change your MA or your time is just the number of electrons, right? So overall number of electrons you send across the tube. So then you get to mass. So a few things with mass. Generally speaking, short exposure times are preferred, and that is because the main thing that will destroy your sharpness or recorded detail, your spatial resolution, is patient motion, okay? And it's one thing you can't, fundamentally, you can't control. You can give them good instructions. You can tell them hold their breath. You can tell them not to move. But if they move, right? So generally speaking, shorter exposure times are preferred to try to eliminate or at least limit motion artifact. So remember, we have two different types of motion. We have voluntary motion and involuntary motion. Voluntary motion is anything the patient can control, even if it's a reflex, like breathing. You don't have to think to breathe until now, because I got you thinking about breathing. So now you're thinking about breathing, and you can't breathe without thinking about it, right? But here in a minute, you're going to forget about that. You're going to be back to reflex breathing. So even though that's a reflex, it's still voluntary motion because the patient can stop it. Involuntary motion will be stuff like, if you're shooting a chest x-ray with lung exposure and the heart blurs the image, or gastric motion. You just can't stop that, right? Also, things like different pathologies. If anybody had a Parkinson's patient, yeah, they have a hard time holding still. You may have to have them grab the table or something to help them to be still. So that would be involuntary motion, okay? So if exposure time, we just talked about that, gets too short, then we'll get into a possible problem with quantum model. Again, this used to be more of an issue with screens and films than what it is now. Our image receptors are so sensitive now that you can use those short exposure times. So you have a couple of things working against you with short exposure times in a theoretical sense. One is the inherent inaccuracy of very short exposure times. Our electronic timers are very accurate, but they have a hard time responding at very, very short exposure times. Okay, so what you've got, you can kind of file this away, but what they refer to the time between the start and the end of exposure is interrogation and extinction time. That sounds kind of, I don't know, spy, kind of like a spy movie. Interrogation time and extinction time is start and stop of the exposure. So at very short exposure times, they might have a difficult time responding that quickly. And in that case, what you've got then is inaccuracies in your exposure time. So you set 1 millisecond exposure and you might get a half a millisecond exposure. Okay, so what is quantum model? It's modelly appearance because of too little mass, right? So what is mass? M-A-N, time. Right, so if you set a time, you're not getting that time, you're getting too short of exposure, then theoretically you could introduce that. The other is the ability of the image receptor to respond to that short exposure time. And again, this is not as much of a problem with our current image receptors as what it was in the past. Your screens of films, for example, they needed a little bit of time to make the exposure. I tried to make this point, well, not really this point, but X-ray film is kind of like photographic film, which y'all have no real exposure to either, but it's sensitive to light. Okay, so I was trying to make the exposure when we were over in Pirtle. We had these screens that would put an X-ray film in and would make an exposure, and we had to take the film out and put it in a processor. And this was done in a dark room with a red light. And so I had the students come into the dark room with me. It's a small dark room, so I only have 2 or 3 of them at a time. And I'd take a film out and I'd put it on top of the counter, and I'd put my hand on the film and I'd tell one of the students to flick the lights. And they'd flick the lights on and off real quick, and I'd take the film and I'd put it in a processor, and what would come out is the film would be totally black except for where my hand was, and then it would be clear there, right? So my point in doing that exercise was, lock the darkroom door, because if somebody walks in and you've got that film bin open, somebody walks in because you didn't lock the door, you're going to expose all the films in the film bin, and it's going to cost us a lot of money. Then I had this one student, she was quick, man. I put my hand on the film and she flicked it so fast that I could see it. I could see the light came on. I was like, wow, that was quick. Let's run it, see what we get. And we got nothing. And the lights came on and went off so fast that the film could not respond and turn black. It was wild. So, you know, bringing that back around to this, our image receptor in that case was not sensitive enough to pick up that light as it came on and went off. So it's more of a problem with screens and films. I don't think it's a problem so much with especially DR image receptors. So proportionality to mass, you know, you've got MA in time. You can increase one, decrease the other. You know, it's half of the equation. So what we, well, we'll talk about that here in a minute. So direct proportionality, and then we don't have mass until we make our exposure. We use our kVp, we send the electrons across the tube. Until we hit the exposure switch, the only thing that we have is MA, right? We don't have tube current, we don't have mass. So somebody can sit there and rotor up all day long with you in the x-ray room, and as long as they don't push exposure, there's no x-rays bouncing around the room. It's just MA. So this is the last thing we'll talk about today. Law of reciprocity. So reciprocity just kind of means, I wonder if it'll fit on that table over there. If I, you know, collapse the legs, I wonder if it's small enough to fit on that table. I don't know. We'll try that. Because it's awfully hard to sit for an hour without stretching your feet out. All right, so reciprocity means give and take. I think we talked about this last semester maybe, but it just means give and take. It mutually corresponding would be another way to put it. So you've got like I use the analogy in a lot of cases of a sawzall. It goes back and forth, right? So you squeeze this little trigger on it, and the saw blade goes in and out, and in and out, and in and out, in and out. So we've got another name for that type of saw. Jigsaw does the same thing, goes in and out, scroll saws, things like that. I think scroll saws. But at any rate, jigsaws and sawzalls do that, and we call those reciprocating saws. Okay, so they go in and out and in and out. So we can manipulate MA in time to get to the same mass value. So if your machine is shooting properly, if your MA and your time settings are accurate, then 100 MA at 1 second is going to give you 100 mass. So MA times time equals mass, right? So we got 100 mass, but what would 200 MA at a half second be? 100 mass, exactly. 400 MA at a quarter second will be 100 mass. That's just reciprocity. It's give and take, right? You're using a higher MA station at a shorter exposure time, you're getting the exact same mass. And as long as your machine is shooting right, within parameters, you should get close enough to 100 mass that your exposure shouldn't really change all that much. Okay, so how we can use reciprocity is to reduce motion artifact. Again, that's the main thing that will mess up your sharpness of recorded detail, and it's the thing that you have absolutely no control over. All right, so we can use it to limit motion, but we can also use it to our advantage. If we want a breathing technique, then we'd use reciprocity and kind of go in the opposite direction. So you shoot a lateral T-spine on a patient, and the lung markings are such that you can't really make out the vertebra all that well. But your image receptor exposure was good. You can use reciprocity, reduce the MA, increase the time, and use breathing technique. or y'all remember the Otnello method from last semester? Wagging jaw? Okay, so this ties back into that first slide where we were talking about tomography, and that I was going to touch on tomography. This is what we refer to as autotomography. So we've got a couple of different means of tomography, and this is one of them. It's using motion to get rid of stuff. So autotomography is patient motion to get rid of artifact. You get the patient chewing, and what that does is it blurs the chin out so that you can see the C-spine. You get the patient breathing, and it blurs the lung markings a little bit on the ribs as well so that you can see the vertebra better, okay? So increase time, decrease MA, same mass, using reciprocity to get to a breathing technique, or to reduce motion, increase MA, decrease time, reciprocity. Okay? Any questions? What you got?
You said that MA and time are directly proportional, but sometimes I'm confused.
No, they're, okay, so in the context of mass, they're proportional to each other to make a mass value. Okay, whenever we're using reciprocity,
Like,
then
the image receptor.
yeah, with reciprocity, what we're trying to do is maintain the image receptor exposure, and what we're attempting to do is either eliminate motion artifact or use motion to our benefit. So in context of just overall mass calculation, you know, they're MA is half of it and time is the other half of it.
Okay.
Does that make sense? Okay. Anything else? All right. Well, I'm here.
How far are you today?